Thanks, Paul. You know, the historical perspective is interesting. Ken Cooper in '68 published his book on aerobics, and it was really one of the first ways to provide metrics on how to quantify exercise burden in a training program. Way ahead of his time. Not in hindsight, we're not too surprised, but things have changed. And one of the hallmark points in our history of exercise was when Frank Shorter, the first American to win offshore the Munich Olympics. We remember the Munich Olympics for more tragic events, but when he won the marathon, it was, some people will say, and I tend to agree, it was the beginning of what became the running boom. So we suddenly saw an explosion of participants, and this is just a teaser of what goes on. I remember I ran the first Toronto Marathon in 1978, and there were 700 of us at the beginning, and now there are 20,000, and Montreal is 30,000, Chicago, and so on. So these have become laboratories to examine risk, but it's a complex terrain because in that population we have a myriad of risk profiles. What I think is important to appreciate is that the population that is participating in the events, apart from the fact that they're increasing in numbers, and even though there may be a bit of a plateau now as the baby boomer population has matured, the trends within the demographics are that there's more and more females doing them, but the largest, and I think I mentioned this earlier, the largest single group and growing still is the middle-aged cohort. We didn't see that many white-haired runners in those events 20, 30 years ago, and now it's the dominance. So with that comes a whole different paradigm in considering risk exposure. So I will argue that the importance of screening in the young athletic population is critical. I wouldn't be here if I didn't believe it, of course, but I would argue that in some cases we put the wrong emphasis on the wrong syllable. That the meat on the bones to some extent is the aging athlete, where you have a confluence of long-term exposure plus the gradual disease progression, which makes it much more complicated. I'll take an older athlete just as an example. I'm afraid it's just all downhill from here. In pretty much every single metric. Right. So your heart gets thicker and it gets bigger, it gets stiffer. Your basal metabolic rate goes down, it gets harder to keep your weight off, resting cardiac output diminishes. It's just those of you in your 20s and 30s and even early 40s, enjoy it because it just is not good after this point. The good news is though, you may, if you exercise, your brain function may be quite good. Although I have a young colleague who just turned 30 and she's an ultra marathoner. I don't know if she's sane, but she goes for 200 and 300 kilometer events. Anyways, as I mentioned, part of what I just want to convey is that the physiology of aging is complex. The heart essentially stiffens, it enlarges to some extent. So too do the arteries, the conduit arteries, and the more regulatory arteries. They become stiffer and less responsive to interventions, and the work of the heart gets greater. There's less and less data actually on vascular function, but there's no question that there's more dysfunction, and along with that, endothelia disruption and the propensity for disease progression. So we really have a confluence of natural disease progression and the physiology of aging in and of itself. And there's ongoing debate as to how closely the two are intertwined. I mentioned that there's also sarcopenic and muscle strength losses that occur significantly after about the age of 50. And there's not just volume and strength losses, there's compositional and distribution changes. So the quantity and the quality of the muscle changes significantly. And that's not all that relevant to this group, but it is, because as I'll discuss later, the loss of muscle mass and the insidious reductions in cardiovascular performance insidiously cause the athlete to work harder and harder, disproportionately so, to maintain what is a diminishing return in their exercise investment. And all of these things conspire, principally cardiovascular, to show a decline in VO2 max, the hallmark of fitness, by just under 10% a decade. And whether you are previously sedentary or highly trained or maintain training, the rate of decline is relentless. You may mitigate those declines slightly in some studies, but by and large, the declines are significant. And they explain why performance levels in middle distance and even in sprint distances decrease because of the changes in cardiovascular and muscle strength performance. We know that the principal reductions are in delivery, the cardiac output, largely because of reductions in maximal stroke volume and age determinant reductions in heart rate. But we also know that there's loss of extraction. Because of enzymatic changes, compositional changes, as I mentioned, and the whole mass of the muscle diminishes as well. So these things, as I mentioned, conspire to force a lowered performance. Both of these are relevant because in the athletes that we've had experience with, particularly in the middle age, there is a disconnect between their perception, even an unwilling ability to consider the fact that their age has affected their ability to compete at very high levels. So we had a 68-year-old endurance athlete who was a cyclist. He had AFib. He had a paroxysmal AF, so he was in sinus rhythm, and he was complaining that over the past few years, he's getting more and more out of breath as he goes up a hill after about 100 kilometers. And I said, that's okay. That's normal. You should be out of breath when you're going up a hill. But he had, and I think that this is fairly common, that there's a perception as we age, particularly those individuals who stay very active, that you think you can maintain the same level of relative intensity, but you can't. So there's a tendency to maintain speed or pace or whatever the performance is at the expense of a higher and higher relative intensity, so that the burden of disease, if it's present, there's an additive factor of a relatively higher and higher relative intensity as exercise progresses. There are exceptions. There's Ed Whitlock, who passed away a few years ago, a Torontonian, who set all of these world records. When he was 72, he broke 3 hours in the marathon. And he would train by running in circles around the cemetery every day. He didn't go on the roads. That was his training. I always used to say people die to train like him around the cemetery. So he was able to run 3:56 at the age of 85. So his cardiovascular performance was really quite remarkable. There's a few things I just want to stretch the perceptions of a little bit as people think about how to deal with an aging athlete. I'm not talking about a high performance athlete. I've made this point before. I think there are 80-year-olds who walk vigorously and they see themselves as being athletes. The weekend or weekday warrior who continues to exercise, even if it's sporadically, they may see themselves as athletes. And I think as we move towards developing either guidelines or knowledge translation, we have to include in the dialogue the aging athlete defined in the broadest sense. Otherwise, our ability to allow the population who we're considering to see themselves in the message is going to be limited. And I think the clinical application is going to be limited as well. There are hundreds of thousands of individuals who aren't even close to being sub-elite, but they are performing vigorous exercise on a regular basis. Not enough of them, but if there's a renaissance of physical activity, unfortunately, it's not in the young population, it's in the aging population. Finding the disease and stress testing and the debates that occur as to who to screen and who not to screen are key issues. And if you have, as someone who I've known for many years, who had absolutely no symptoms, was a regular enthusiastic cyclist nearing the age of 78, but he had a terrible family history and he just wanted to find out. He just wanted to find out if he was safe. And one thing led to another, and somehow his family physician got him in
for an angiogram. And 3 stents later, 190% in his left main, he's absolutely fine. He's back to cycling. So how do we identify the individuals with occult disease who may be fine, and what may differ between an emerging middle-aged adult who has a vulnerable plaque, who may be perfectly fine on a stress test because they've got collateral vasculature and they don't have a flow-limiting lesion at the time of the stress test. The next day has a sudden cardiac event. These are the difficulties in my mind. I also just want to point out that times have changed. There was a fellow named Bassler. We used to call this the Bassler effect. There was a dialogue and exchange across a couple of different journals in the early 70s. I quote, "We've never seen a case, at least our own or reported in the literature, of a fatal coronary heart disease in an individual who had finished the marathon." So when asked, how do I avoid a heart attack? The answer was, assume a lifestyle associated with immunity to heart disease, the marathon runner. Now, of course, we know that this is completely untrue. However, as was discussed earlier, there is a perception amongst a number of individuals who run chronically or who cycle or who do regular activity that they have some confirmation of immunity. And they'll even to the point of dismissing prodromal symptoms. And it may even be a form of embarrassment that they may even have heart disease in spite of what they've done. Maybe it's the fear of the ridicule that you've done all of this exercise and you still get disease. I think it's an interesting psychology, but we need to address it in how we tackle this aging population and disease risk. I'm going to go through some of this quickly, because I know you've all been in your chairs a long time. Most of the older adults, well over 90 to 95% of them have atherosclerotic heart disease. We all wish that the needle was this big in the haystack, but it's not. And so the identification of disease is really the big challenge. But balancing the challenges of what's cost effective and what's accessible to the population without dissuading people from exercise is the real tipping point. Dr. Bagish has published extensively, so I'm not going to spend much time on this, but ascertaining who in that population of marathon runners has disease without symptoms. Some of the literature will be as low as 9%. Some of the literature will be as high as 20 to 25%. But there's no question in that cohort of 30,000 marathon runners, there's a few thousand that have disease. How vulnerable those individuals might be is the big question. One of the studies that looked at calcium scores suggests that the percentage may be as high as 20% when composite assessment of atherosclerotic presence is there. And this has become a bit of a hot topic in the athletic population. And in fact, some papers, enough papers have come out with consistent findings that although I question the applicability of them, they're individuals who have a high level of cardiorespiratory fitness, but more strongly, individuals with a long history of exercise have higher calcium scores, even when compared to normal non-active individuals. However, when you look at the composition of the calcium, it suggests that individuals with long-standing exposure may actually have more calcific plaques and may be somewhat protected. So if I had to choose being sedentary or an athlete with calcific heart disease, or being a young neophyte, a middle-aged adult with vulnerable immature plaque, you know who I would choose. So I suggest that these observations are very nascent in their understanding, but I suspect that there's some benefit. And we can't, it's contra to what we know in the literature, that individuals who have long-standing history in exercise as they age have relative protection, not immunity, but relative protection from disease. The controversy rages on about who should undergo a stress test. The American College of Sports Medicine, not too long ago, really wanted to abandon and recommended the abandoning of trying to come up with composite risk scores based on an aggregate of how many risk factors you had and age. And one of the salient predictors of risk was prior physical activity. So this is more of a guiding set of criteria for determining who has who should have a risk assessment by stress testing. And I remember years ago when I turned 45, my physician, and this is, I think, a very classic example of what goes on. He said, you know, you should have a stress test. You hear all these guys having heart attacks on their bikes. And I think he was maybe talking to the wrong person, but I said, you know, there's not a lot of evidence that I should have one. Well, I feel better if you did. But I have a stress test every day. Why should I get a stress test? I think he wanted really, he joked, well, then get a colonoscopy instead, which I did not do for another few years. But so I finally took the referral slip, and when I got home, nothing was checked off. He didn't check off whether it should be a nuclear scan, a stress echo, a stress ECG. And of course, when I called him and I asked him, Alan, which one would you like me to go to? He said, oh, I don't know. You just pick which one you think is best. And I proceeded to do absolutely nothing. We talked about hockey, so I added these in between one of the breaks. It was an interest of mine for a number of years, and I shelved the project until my, excuse me, until my son came back to U of T to do his master's degree. So I handed a colleague right next to me a little bit of funding that I had and a protocol for a study, because I was interested in really quantifying what the so-called cardiovascular burden was in middle-aged men playing pickup hockey. And pickup hockey is a different game, really, than an organized hockey game. It's high intensity, which is true for all hockey games. There's a lot of gliding, and when you're gliding, you're doing isometric work so that there's still a significant load and impediment to blood flow. There is a tremendous heat buildup, similar heat buildup in pickup hockey than there is in tackle football, because of the uniform and the heat retention. And what was always dogging my thoughts was the intermittency of the sudden exercise, but not just the exercise, but the sudden complete stationary bouts in between the exercise. So I always wonder, are they at greater risk when they come to the bench and systolic blood pressure remains high, but diastolic pressure may be dropping as the heat buildup goes on, and hence the perfusion pressure may be affected. So, and this is just a simple graph showing polar heart rate data during a pickup hockey game, actually from a number of years ago. And you can just see the intermittency, but the heart rates remain high. So we asked this a couple of questions. I guess this didn't copy perfectly, but this shows heart rate drift, which is common with prolonged exercise, but this is only 60 minutes. And the top solid bar is heart rate during the game. And you can see a substantial drift, and that's heart rate at recovery, which means that the diastolic filling times are less and less and less. Perfusion time is less and less and less. Diastolic blood pressure continued to drop. So, which theoretically, if there's an environment of disease, you may be creating a milieu that may be pro-ischemic. And when we calculated the diastolic time tension index, which is a crude index of myocardial oxygen exposure, you can see that data go down. So it was interesting, and it was certainly evident that the pickup hockey in a typical game is a significant stress. I think what was more interesting, though, is when we did stress testing on these individuals before, the achievable peak heart rates and systolic blood pressures during maximal exercise testing were exceeded during pickup hockey. So to confer a sense of safety in a middle-aged adult, they had a clear stress test, go ahead and play hockey, maybe giving some false confidence. A couple of final notes. If there's ever any doubt about exercise being safe, we have a long history of intensive cardiac rehabilitation to draw upon in well-established disease. And a mentor and colleague who's now passed away, Terry Kavanagh, really showed the world in 1973 that you can take a group of cardiac patients who had an interest in running, and they could train and successfully complete the Boston Marathon. And he was scolded and ridiculed and he was accused of being a renegade and a showboater. but he really was a pioneer in this regard because he showed that exercise was safe and that high levels of performance could be achieved. He later went on to show this in heart transplantation as well. We've also done some work with high intensity interval training, and these are data from somebody else who did a really nice review showing the efficacy of HIIT, high intensity interval training, or moderate intensity training in cardiac patients. And the evidence is that it's safe. There's low rates of adverse responses, and it may be a very effective way to train. And some of these comments were made earlier. Prodromal symptoms exist in many individuals, although in some, the first sentinel symptom, as you know, is sudden cardiac death. But prodromal symptoms also include symptoms that don't occur during exercise, and that subtle, insidious decrements of performance is one of many. And these things we need to educate the public more to listen to their bodies very carefully. I've already said that athletes are not immune to heart disease, and that they may well be exercising at very intense exercises, more and more so as they age, particularly if they're trying to maintain high levels of performance. And I think if we ever get to providing knowledge translation and guidelines with respect to safety in middle-aged adults, we really have to make sure that we target the right population. The first people on the scene to deal with these individuals are not the highly trained specialists. They're the family physicians. And they're the ones that are going to be sending them for a stress test unnecessarily or not. And I think the other message is that we have to, and Kim Connolly said this earlier, exercise is safe. It's far safer than sitting. And we need to remember that in contextualizing all of our messaging. And I think that's our biggest challenge. How do we, in a sensible way, convey to the population that we can, and that primary care physician, that exercise is safe, but we can mitigate the risks in an appropriate way. And I think appropriately for the middle-aged population. That's it for me.